On this last section of cardiac muscle basic, I want to return to another look at the electrical circuitry of the heart, and I want to tie this into some embryology and then the innervation of the parasympathetic and the sympathetics. As I've said before, the internodal pathways, specialized myocardial cells that rapidly conduct current from one point to another point. Histologically, if we're talking the ventricles, these are again non-contractile, so they don't have much in terms of striations. They may have some indistinct boundaries. Now, this is in distinction for the internodal pathways in the atria, which again, they're very difficult to see because the internodal pathways of the atria are in fact contractile, so they're indistinguishable from the surrounding cardiomyocytes that also contract. And as I've said before, the pacemaker nodes are heavily innervated by sympathetic and parasympathetic. So again, you have a sympathetic tone coming into the heart. You have a baseline parasympathetic tone coming into the heart. So as far as the heart is concerned, the autonomics, I got a little bit of pressure on the brake pedal and I have a little bit of pressure on the accelerator, and they're working off each other. If we're talking about the preganglionic sympathetic fibers to the heart, they're going to arise mostly from the stellate ganglia. Now, the stellate ganglia is going to be the ganglia that is formed when you have your inferior cervical ganglia and it fuses with your first thoracic ganglia. And some people have a stellate ganglia, some people don't. So some people, they have a separate inferior cervical ganglia and a then discrete T1 ganglia. So when that happens, then the input can be from one or the other to the heart. But if they're fused, then they're coming from the stellate ganglia itself. So if you remember, the postganglionic fibers are the fibers that actually make it to and act on the end organ itself. So if that's a little fuzzy to you, I'm asking you to go back and relook at the autonomic notes so you can get a better sense of what we're talking about. The SA node is developed from the right side of the embryo, which is why it is supplied by the right vagus nerve and right side sympathetics. So here's the SA node, develops from the right embryo, and it's going to be fed by the right vagus nerve and the right side sympathetics. Whereas your AV node develops from the left side of the embryo, and it's going to be supplied by the left vagus nerve and the left side sympathetics. So the AV node is going to be the left. Now, this is not that hard to remember, because if you are looking at this, from anterior posterior, this is right side and this is left side. And so you could split it up. So what's on the right side is going to be your sinus node. Well, that's right side embryo, left side just a little to the left. And so that would be an easy way for you to remember the left sympathetics, left vagus nerve, right sympathetics, right vagus nerve in terms of what innervates which node. So I don't think that's hard to remember. All right, so a clinical point here, you've heard of what is called a carotid massage. And this is something that a healthcare worker can do to actually slow the heart rate down. And this is something you would never want to do to anybody else, because there are possibilities of things going bad with a carotid massage, but in the hands of a professional, this is something that you could do. So let's talk about what a carotid massage is. So if you recall, the carotid massage is going to be associated with a carotid sinus. Carotid sinus there. The carotid sinus is going to be that area right where you have the bifurcation of the common carotid artery as it bifurcates into the internal carotid artery and the external carotid artery. Right there is a sinus, and that sinus contains numerous baroreceptors. So that's the area there that is basically sampling arterial blood pressure. So what's going to go on here is that carotid sinus innervated by the glossopharyngeal nerve, I guess cranial nerve 9, glossopharyngeal, and that particular nerve that innervates it's called the sinus nerve of Herring. It is a afferent fiber. In other words, it is basically there to sense something at the carotid sinus. And what it's sensing, of course, is pressure. And then it's going to be communicating back to the central nervous system. So it's going to be delaying information from that sinus, and it's going to communicate back to another structure called the nucleus tractus solitarius, which is located in the medulla of the brainstem, or the medulla oblongata. So the lower part of the brainstem, there's a cluster of neurons there, and they're called the nucleus tractus solitarius. It is receiving information from the baroreceptors from the carotid sinus being conveyed by the glossopharyngeal nerve, in particular the nerve of Herring. So once that information is communicated to these neurons here in the medulla, that then is going to be communicating the information to the dorsal motor nucleus of the vagus. The dorsal motor nucleus of the vagus is also a cluster of neurons sitting in the medulla of the brainstem. Those neurons are motor neurons, but they're motor neurons associated with the autonomics. So the neurons associated with the dorsal motor nucleus of the vagus will send their axons out, riding down the vagus nerve, and then will communicate to the AV node, SA node, and other areas of the heart as well. So the neurons of the dorsal motor nucleus of the vagus will ride down the vagus and will talk to the heart, and those are going to be your preganglionic fibers going to the heart, which means then they are going to then be communicating with other neurons very close to the heart. Then those neurons will in turn synapse onto the various regions of the heart, delivering their acetylcholine for their desired effect. As far as, and another thing that they're going to do, once you have the communication from the nucleus solitarius, again, which is going to be receiving the information, not only is it going to talk to the parasympathetic side of things, it's also going to be talking to your sympathetic side of things. And you'll recall the sympathetic nerves that are coming to your heart and the rest of your body, okay, they're going to be coming from your intermediolateral cell column. In case you're IML or IMLCC, remember that is in your spinal cord, that is T1 through T12-ish, somewhere along in there. Okay, and they're going to be giving rise to the postganglionic parasympathetic fibers. The postganglionic sympathetic fibers going to your various organs. So your IML or your intermediate cell column, that's your sympathetic system talking to your organs, in this case, the heart. So now I'm having my input from my parasympathetic component, vagus, and then my sympathetics, and talking to the heart. And so they are then communicating or modulating heart function relative to the signal that was delivered to the brainstem, the nucleus solitarius, telling the brainstem, hey, the pressure of the arterial system is this or that. So the reason that you'd want to know that is because if the pressure of the arterial system is too low, then what's going to happen, you're going to have an adjustment on that brake pedal and that accelerator. So if the pressure is too low, then you would want to maybe back off the vagal input and increase the sympathetic input to cause the heart to beat a little more forcefully and a little more rapidly to bring the pressure back up. Or if the pressure is too high, then you might want to lay off the accelerator, maybe tap a little bit on the brake. So you might want to back off on the sympathetic tone, increase the vagal tone a little bit to slow the heart down. So you have some modest ways of regulating blood pressure relative to heart function. So that's what the carotid sinus is all about. So we're using that knowledge to basically trick the system. So if you are then palpating the carotid sinus and just massaging it, what you're doing is you're increasing the pressure at that little area that you're massaging. And so if you're increasing pressure, basically you're telling the carotid sinus that, okay, I've got too much or I got additional pressure in the arterial system. I might want to go back up to the brainstem, let my autonomics know the pressure's running a little high, and then make an adjustment in terms of my parasympathetic, sympathetic, and slow the heart down. And that's exactly what will happen. So if you do a carotid massage on somebody, it's actually going to slow their heart rate down and lower their blood pressure. Now, when you do this, you don't do the massage more than maybe 5 seconds to get the effect. But this is a maneuver that could be done if somebody is in supraventricular tachycardia, if their heart is beating too rapidly, and again, it was one of many things you could do that's very simple to slow the heart rate down. It can also be useful in treating atrial flutter, also atrial tachycardia as well. Again, it is quite useful. Now, the reason that you just don't want to do it yourself is because when you are massaging the carotid sinus, that person may have plaques built up in there, and if you're physically manipulating the carotid sinus, you run the risk of compromising the integrity of the plaques. You may agitate them, they may break off, they may become a clot, an embolus. So it's pretty high risk in the sense of massaging those. You need to know what you're dealing with in terms of the patient. So this is why a normal person off the street, you would not want to do that, because you could end up hurting somebody by dislodging a plaque or something or causing an embolus. So again, this is something fairly serious. You want to be very careful about that. But anyway, so that's what a carotid massage does. And it's, again, it's one of the tricks in the bag that you can use to slow the heart rate down for somebody. My last topic is, this is just more of a practical thing. It has nothing to do with what I just talked about. Basically, what I want to do here is show you a quick and dirty way of estimating the rhythm of a heart when you see an ECG. So you will recall that 1 square is 0.04, or 0.04 of a second. Okay? And you will recall that you go from QRS to QRS. And so if you could measure the time from here to here, then you can estimate or you can calculate what the heart rhythm is, but you got a lot of little small boxes between there. So you don't want to do that. There's an easier way to look at an ECG and very quickly determine what the heart rate is. So the way you do it is you memorize these numbers here: 300, 150, 100, 75, 60, 50. Just get that in your mind. That's what you do. So once you have that down, you have a very quick way of looking and determining what someone's rhythm is. So if you look on an ECG paper, you'll see the small boxes, okay, right along in there, but you also have big boxes. And so the big boxes would be there. Okay, and so as far as time is concerned, you're going to have 5 little boxes make a big box. So you got a here, and then here, and then here, and so forth, so on. So easy to see in ECG, the big boxes. So what you're going to do is you're going to look for a QRS complex, and ideally, if you can find a QRS complex where the R wave is going to be corresponding to one of these big box lines, like right there, and then you're going to quickly look and see where the next one is, and you're going to count big boxes. So again, this lines up with this. So remember, I got, the numbers need to be assigned to the boxes. So the first big box is 300, second big box is 150, third big box is 100, fourth big box is going to be 75, so forth, so on. So if you were to look here, you got a QRS here, and I don't know anything else, but I'm looking at the big boxes, and I'm counting big boxes. One, so I go 300, 150, 100, and the QRS is between 100 and 75, so you know then the rate is going to be somewhere in the normal range. So basically 1, 2, 3, and then a half. So heart rate here is probably around 80-ish or something like that. And so that'd be a pretty good estimate of what the heart rate is. So just get used to counting the big boxes. So if you were to look at an ECG and you saw a QRS complex here and you saw a QRS complex there, what would the heart rate be? Real quickly look at it. You know it's going to be 150. 300, 150. So the heart rate is 150. How? Because the interval between the two R waves was two big boxes. Two big boxes, 300, 150, so 150. Of course, then you may go say, well, what happens if I don't have that QRS wave lining up to on a big box? You can still ballpark it. Suppose you have a QRS complex there, okay, and you have a QRS complex there. What's in the middle of that big box, and it's the middle of that big box, that's still two big boxes. So two big boxes, so that means if I have that interval there, my heart rate is going to be 150 beats per minute. So you can get pretty good at this, but you're going to want to develop this skill just to look at it very quickly, boom, 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 just 300, 100, 300, 150, 175, 60, 50, and within 2 seconds you can look at what the rhythm is. So again, a little trick and a little skill that you want to get good at. Anyway, so that's it. So that concludes our chapter on the basics of cardiac muscle. And so next we'll go into in more detail on some of the things that I lightly touched on in this section here. All right, so I'll see you next time.